Welcome to the NewlyMeds podcast. Any views or opinions expressed in this podcast are our own and do not reflect the views of our employers or affiliated organizations. This content is for informational purposes only. Always follow your local policies, protocols, and medical direction.
What is up, guys, and welcome back to another edition of the NewlyMeds podcast. Today, we have another awesome episode that we're really excited to bring to you. We're going to continue talking about these trends of really high acuity calls that we don't see that often in the field. With that being said, today we're going to dive into postpartum hemorrhage and a little bit more about what postpartum hemorrhage is and how we can manage it when we're out there in the field. And so, when I think about postpartum hemorrhage, really I'm thinking about more than 500 milliliters of blood loss following the delivery of a baby. And in nursing school, something that I didn't really ever think about when I was a paramedic was how postpartum hemorrhage can come about. It's not something that when we're in paramedic school or EMT school, because of the sheer time that we spend with patients, I think we miss how long it could take to acquire postpartum hemorrhage, but also how rapid it is. So I felt like in paramedic school, they're always like, this is happening, immediately. There's going to be so much blood loss, and it's just like your massive trauma patient, and it's just going to all come out at once. Everything's going to bleed, and you can do nothing to stop it. But when I was in nursing school, I looked at it from a bit of a different perspective because of my maternity class. And that 500 milliliters can come anytime, really, within that 24-hour period following delivery. And so, if there's a small amount of bleeding that's just occurring consistently every hour after that baby's delivered, that amount of blood can add up pretty quickly and contribute to this postpartum hemorrhage, especially if we're not replacing that blood loss. So, as we're losing that 30 ml, that 50 ml an hour, and those pads are soaking through, and we're not really keeping track of how much blood is being lost and we're not replenishing it, that's really where things can catch up to this patient. And then that's when we see them crash hours after delivery. And so, it was really unique for me to know that it's not always going to be something rapid. And especially in EMS, we're probably not going to see the effects of that slower blood loss. We're really only going to be worrying about that rapid, massive hemorrhaging that might occur. But it is something that we want to keep in the back of our heads, especially if we're seeing a patient on an interfacility transport that is X amount of hours postpartum. That's something that I definitely would want to ask the nurse, like, hey, how many pads have they soaked through in the last few hours? Some questions like that so that I can get an accurate gauge on really what all this postpartum hemorrhage is about. And so when we look at postpartum hemorrhage, it occurs in about 1 to 5% of deliveries in the United States. And so not a huge amount. And I think that you would talk to any paramedic and they'll say, like, every delivery I've ever had in the field has been fine. I myself have told Dan recently as well when we were prepping for this episode that I've never had a field delivery that has not gone successfully. It's always been really nice and easy. A lot of stress. It's definitely not one of my favorite things to do. You very quickly acquire two patients instead of one, and there's a lot of things that need to get done. But thankfully, everything's going off without too much complication. And I've never had any severe postpartum hemorrhage. So doesn't affect a lot of patients, but the patients that it does affect, that population, it can be very lethal very fast. And so it's also something that's extremely preventable. And so when we think about this, I always think about the tone. So how is that uterine tone in the mother? And so is that uterus really boggy and soft? And as we're doing that fundal massage, is that doing anything to stop the bleeding? Then we're thinking about the tissue, if there's any retained placenta inside the mother as well. Trauma and types of lacerations. And you talk a lot about that in nursing school, not so much in paramedic school, but the different types of lacerations and classifications that can occur in a delivery. And then how that patient's actually coagulating following the delivery. And so when we look at postpartum hemorrhage in the field, again, you're going to see some either rapid bleeding, especially when it's those severe cases, and you're going to see that patient bleeding a lot in a very short amount of time. And then often in the hospital, sometimes you're going to see just persistent bleeding. So bleeding that's we're soaking, soaking a pad an hour, a couple pads an hour, and maybe we're not doing a good job at tracking that blood loss or replenishing it. And those are the ones that really sneak up on you. Similar with shock is we want to look for the cool, clammy skin. We want to look for the diaphoresis, the power, decreasing levels of consciousness or anxiety in those patients, really all those signs that your patient is being hypoperfused, we want to be on high alert for when there's postpartum hemorrhage because again, like all patients that go into shock, they can turn that corner really quickly and then things get really bad, but it's so preventable. If we're just on top of our craft, on top of our assessments and recognition in the field, we can really do a great job at preventing any sort of mortality in these patients because it can be and is documented as a very lethal thing when it's not caught early enough and the steps aren't made to correct that postpartum hemorrhage. So Dan has a little bit more that he's going to go in depth, and we're going to talk about a lot of different things throughout this episode about how we can manage postpartum hemorrhage, some additional things that we want to look for, and I know Dan has a case that he wants to talk to us later down the road about as well. So Dan, what else can you tell us about the postpartum hemorrhage in the field?
Well, yeah, and I think you brought up a lot of really great points that I wanted to touch on as well. Is that when we think about this from a pre-hospital recognition and a management standpoint, there's a lot of things that we can do that we can look for that will help us catch this early and to help us mitigate some of this hemorrhage in the, as well mentioned, the short period of time that we're with these patients, especially if it is a pre-hospital 911 call versus like a hospital to hospital transfer. But I think one of the big things that you brought up was retained products of conception. I think that's one of the things that we need to better ourselves in looking for. And when I say that, obviously we're not going exploring or anything like that, but what is the clue that we can use to tell us if there is potentially retained products? And that is, so does the placenta appear intact? Does there appear to be any, massive chunks or sections missing from that that could still be within the mother, right? And I think that's one thing we often glance over. We deliver the placenta, we quickly look at it, we throw it in the little bag that's in our OB kit, and we move on to continuing to care for mother and baby. And I'm not saying that we need to spend a lot of time with it, but we do need to take a closer look at that and make sure that it does appear in our best judgment intact for what we're looking at there. So I
Mm,
think when we think about other focus points for pre-hospital recognition is also what is the amount of bleeding. I think we often underestimate, number one, the amount of blood loss, and number two, the amount of time that it can take, as Will mentioned, for this blood loss to accumulate, as well as we often just kind of associate, yeah, there's going to be bleeding with a pregnancy, we say, or with a delivery, we say that that is normal. And again, we just kind of glance over that when in reality, yes, bleeding is obviously normal with a delivery, but we need to be doing better with actually trying to quantify that amount of blood loss. And as Will talked about, monitoring that. Studies show, and as always, our studies will be in the show notes, but studies show that just a brief visual estimation is usually underestimated by EMS providers by 30 to 50%.
yeah.
I know Will and I were talking about this. I know when we've done previous, maybe not necessarily on the podcast, but when we've done previous discussions in trauma and ITLS and those types of topics, uh, there's a what's called the MAR method, which is simply just taking your fist and basically counting how many fists, the surface area of your fist, how many of those you can approximate for the blood loss. And each fist is about supposed to be about 20 mLs.
Yeah.
So that is one of those just real quick down and dirty estimation methods that we can use to try and get us closer to a more appropriate estimation. And I think another really great point that you brought up, Will, is greater than 500 mLs of blood loss. We think, oh, that sounds like a lot, but think about your 500 ml bag.
Yeah.
It's not this massive number that can start to cause hemodynamic instability. And with that being said, if there's hemodynamic instability, even if it is 300, 400, we're still going to classify that as a significant postpartum hemorrhage because that is enough to lead to that instability. So I think these are all things that we need to be very mindful of as we are. And as Will said, this is a very fast-paced call. This is a very high acuity in the sense that there's a lot that could go wrong. Most of the time, this is a natural progression. This is a natural act that has occurred throughout the entirety of mankind. But this has the very high propensity to go wrong. And so we need to make sure that we are hyper vigilant with all of these different aspects. So, what are some of the things that we can do to mitigate this? Will briefly mentioned about the fundal massage. If if it's within your protocols to do so, make sure that we are doing that and make sure that we are doing that appropriately. If you don't know how to do it, look up. I mean, it's kind of hard to talk about it on a podcast and actually show and demonstrate that, but look up how to actually do one. It's not Buddha. We're not just giving a quick little belly rub. This is a potentially uncomfortable procedure for the mother, but it is a very beneficial procedure for so many different reasons.
Yeah.
This
One thing I would
stimulus.
recommend do with that, Dan, is something that I got to have the opportunity when I was in paramedic school, was to go to a women's hospital and see a labor and delivery floor. But I never really understood until I got into nursing school, and um, they force you in nursing school to do
Right.
a lot more, and it's one of the huge benefits. But I would urge new providers, talk to a nurse, not just an ED nurse, but if you have the opportunity, try to talk to a labor and delivery nurse because they have so much knowledge on this topic specifically. And if you're wondering where the uterus is after a delivery occurs, or even where the uterus is throughout the pregnancy, they will tell you where it should be, what it should feel like, how to do fundal massage, and trying to get hands on with that. I mean, videos will show you a little bit, but it doesn't compare to real life and it doesn't do it justice. So I would urge you to really go out there and talk to your L&D nurses. They are the best resource for this.
Yeah, absolutely. And they love, in my experience anyway, if you approach them and say, "Hey, we are trying to get better as a profession with appropriate treatment of these patients and learning your craft essentially," they love to give you that information, at least in my experience.
Yeah, they're really proud to be L&D nurses,
Yeah,
and
yeah,
rightfully so. It's a very difficult specialty and subspecialty of nursing. Again, I complain when one patient turns into two, and that's their everyday life.
right.
This is something that they do on a day in, day out basis, and they are proud of it, and they are very well knowledged, and they're very eager to share that knowledge. And it's something that we really need to do a better job at in the field because we just don't see it that often. And so, gaining some of that knowledge from our peers is really vitally important.
Yeah, absolutely. Yeah, to finish up on on the fundal massage there, why that is so important is this actually helps contract and compress the blood vessels where the placenta was located, or excuse me, where it was attached. That helps reduce blood flow. It also helps dislodge and expel clots. It also helps keeping the uterus from becoming relaxed. So it helps keep that uterus firm. It helps to ensure the tone, like Will was talking about. It helps restore that tone within the uterus, and all of this helps constrict and contract and compress these blood vessels. That's going to ultimately help decrease that bleeding.
Yeah.
Outside of that, make sure that we are, taking any other type of standard resus measures. O2 as needed, large bore IV access, fluid resus. But when we're doing fluid resus, we want to make sure, and it's the same type of concept we use in trauma. We want to make sure that we're doing this judiciously. We're not just hooking up 2-liter bags and setting them wide open. This is not the late 90s, early 2000s. We're not doing that. Permissive normotension is perfectly acceptable in making sure that we are not flooding them out with isotonic crystalloids versus whole blood, which we'll get into later. And just make sure that we are tracking and trending those vital signs to make sure that we are trying to stay within that good perfusion window there.
Yeah, and really look at the map. That's a little bit of the ICU nurse in me.
Yeah,
Um,
absolutely.
but it's something that we get on our cardiac monitors. It gives it to us. That map is really important, especially when we're talking about resuscitation in these massive blood loss patients. Um, Allowing that map to be within your protocol's range around that 60, 65 mark, I think that's more than appropriate as long as we're perfusing those vital organs.
Absolutely. And a couple quick more pearls would be, obviously we want to not delay our transport. We want to get to the most appropriate facility in the most appropriate way possible. If that means going a few extra minutes to an LND capable hospital versus not, that is a field decision that you're going to have to make based on your protocols and based on your best judgment with where you are and what facilities you have. But also make sure that we are early activating OB alerts if you have an OB alert, or if it is this postpartum hemorrhage, a trauma alert if they qualify for that. Make sure that we are having that early notification to the hospital, to the receiving facility with all of the appropriate information. Not just simply, hey, we had a delivery, but what is the blood loss? What is the timing of the delivery? Was this a prolonged event? Was this an uncomplicated event that turned complicated? Make sure that we're giving them this information so that way they can best prepare based on their protocols to help continue the resus of this patient. And then I think with that being said, I know we've kind of talked and teased a little bit about blood and TXA. So, well, why don't you kick us off with some farm and other management there?
Yeah, Dan, I think it's a great point that you made, getting into the background and really just starting out with the basics, right? So before we even think about the pharmacologic interventions that we can do, making sure that we're doing that fundal massage, making sure we're doing it appropriately, and trying to get the uterine postpartum to just contract itself, right? Like the same rule applies when you see any trauma patient. I'm not just going to throw a tourniquet on you right away. Let's try direct pressure. And if that doesn't stop the bleeding, then we take our next steps. Let's try fundal massage and go from there. With that being said, there's a number of options, especially now as EMS is progressing, as more medications are being put into the field, as we use whole blood. There's a lot of things that we can do with our postpartum patients. And so, one thing that you spoke about earlier was TXA, and I want to dive into that a little bit deeper. And so, when we talk about TXA, I think we've talked on the podcast before about the CRASH 2 trials and everything like that. But specifically with postpartum hemorrhage, there's a trial called the Woman trial. And I would really urge you to go to Rebel EM's page, which is a really significant website for anything emergency medicine. And they do a great job at simplifying these complex studies, especially making them pertinent for emergency medicine and looking at what they do. But when we're giving TXA, it's that antifibrinolytic therapy that's going to prevent the clot breakdown. And so it's going to stop that plasmin from turning into plasminogen. And so we're going to give that gram or 2 grams, depending on what your protocol says, over 10 minutes. And we can repeat it if the bleeding continues to persist. But the main thing with this isn't really how much we're giving, when we're giving it, but why we're giving it. And so when we talk about this woman trial, it was one of the guiding trials, I think, for looking at TXA and postpartum hemorrhage. And they looked at TXA in a number of different female populations, females that were pregnant, like hysterectomies and different things. But as far as postpartum hemorrhage goes, there was a very significant difference that supported TXA on death because of postpartum hemorrhage. And so the patients that had that TXA, they really improved and didn't have as much mortality as a patient that didn't receive the TXA. And so it's really showing some promise at reducing some of the maternal death that's caused by bleeding. It was looking at about 31% when it's given within 3 hours of birth. And so, as far as TXA goes, we look and talk about it for a number of different things. We're starting to talk about it with trauma patients and bleeding, abdominal bleeding. Obviously, now we're talking about it with postpartum hemorrhage. I think it's a great tool. I think it's really amazing that it's starting to come to EMS. It's starting to be more widely adapted, and that paramedics are out there using this. Again, like any tool in our box, we want to be really cautious. And so, one of the data points that really doesn't talk about was, are there any clotting abnormalities? So, after I give TXA, how at risk is my patient for adverse clotting effects? So, DVTs and PEs, those things that we talk about that are really critical for any patient, but especially the postpartum patient that's really at risk for these. It's something that I would think about. It doesn't mean that you should or shouldn't give it, but I would definitely recommend looking into the literature, looking into best practices, and it does show a lot of promise. And so if I'm not going to use TXA, maybe what are some other options? And again, going back to nursing school, I was really fortunate to learn more about maternal medications and some different things. And we talked a lot about oxytocin or Pitocin. And so many times you'll see on an L&D floor, Pitocin's given prior to birth even occurring. And so it's going to stimulate the uterine contraction. It's actually going to encourage the baby to come out and be birthed. But it's also given in this postpartum period. And so it does that because it still stimulates that uterine to contract. And so it's going to increase the tone of that uterus and it's going to reduce bleeding that way. And so if it's within your protocols in the pre-hospital environment, it's definitely something that you would want to consider. Now, one of the pearls that you have to know with this is Pitocin's not going to work if the uterus is not intact. And so, if you know that this is a very traumatic postpartum hemorrhage where the uterine has ruptured, any sort of thing like that, Pitocin's really not going to be your best bet. And so, oftentimes, I think in the pre hospital setting, like I talked about earlier, we are seeing a rapid loss of blood. When we're talking about postpartum hemorrhage in EMS, oftentimes it's something that comes on very fast. There's a large amount of blood loss in a short amount of time. And I would say that Pitocin might not always be your best bet. At that point, we really need to look at alternative ways to stop and correct that bleeding and really take care of that patient and get them to a high level facility that can care for them even more so than EMS can. But for these interfacility transports, or even some cases in the field, Pitocin may not be a bad idea. If you're doing some fundal massage and they still have some persistent bleeding, but they're not rapidly hemorrhaging, I think it would be really important to consider Pitocin. Maybe we can slow some of that bleeding, especially if it's something that Dan talked about earlier, is we don't really do a great job at recognizing how much blood is actively being lost. But if we're seeing, some bleeding that we just can't get controlled with fundal massage, it's definitely something that I would want to consider. And so again, always following your local protocols. Typically, you're going to see about 10 units to 40 units with some normal saline or lactated ringer solution. But again, you have to make sure in these patients that the uterus is intact. There's no reason to give Pitocin if you have a uterine rupture. It just won't work. There's nothing to contract. It's trying to contract that uterus. And finally, something that I know we're all really passionate about and is really exciting in EMS that we're finally making the steps to acquire these things. And a lot of systems in the United States already have it at their disposal, but whole blood and blood products. And I talked about this earlier in the episode, saying, especially in these cases that the bleeding doesn't occur rapidly and it's occurring over a few hours, but then it's just accumulating and we miss it. And that blood is never being replenished. Again, I would urge you to go to an L&D floor. And I think that you would see a lot of these patients get maybe just a unit of PRBCs over an hour. It's not even rapidly infused, but it's just something to put back in because they went through a pretty traumatic event on their body, which is giving birth. It's not, it is a normal part of life, but it's by no means easy. And it takes a lot out of a woman to deliver a child. And they lose a lot of fluid and blood. And that all needs to be replenished. And so within EMS, we need to do a really good job. And Dan alluded to it earlier at not just replenishing the fluids but replenishing the blood. And we talk a lot about this. Even Dan said earlier with our trauma patients that we're not just trying to fill our gas tank back up with water, right? When you go to fill your car up with gas, you put in gasoline, you don't put in vegetable oil, at least in most cases, unless your car is really cool and does run off vegetable oil. But you put in your vehicle whatever it runs off of. And our vehicle, our human body, runs off of blood. And so, yes, we can provide a little bit more volume support with our crystalloid solutions, such as our normal saline or lactated ringers. But at the end of the day, that's not what the body needs. The body needs more blood or blood products. And so, with these patients that have severe postpartum hemorrhage, I would urge you, if you're a facility or a agency that carries that whole blood, really think about using it and using it sooner than later. And there's a number of studies out there with EMS whole blood and pre-hospital whole blood, but especially after blood products and whole blood have been used in a hospital setting, there's really good data points, and I would urge you to look into them about how the early administration of blood and blood products really improves patient outcomes and reduces some of the mortality associated with large hemorrhaging, whether that be trauma or postpartum hemorrhage, but any sort of significant blood loss. And so making sure that we consider the patients that need and meet criteria to receive this blood or Pitocin or TXA is really important. Assessing the patient, making sure that we're not giving a medication that has no purpose. If there's a uterine rupture, like I said, that Pitocin isn't going to work. And then with the whole blood, obviously, as it's new to EMS, there's a large amount of training that goes into it. Even just getting blood to be acquired in your agency, there's training that goes in before you ever even receive a unit of blood. You need to be competent on it. But no call is high enough acuity for you not to do the small things right and take a deep breath and take your time. Making sure that that blood and that blood product is the correct unit of blood, it's the right patient, that all of those steps, all the rights of medication administration are being performed correctly. And especially being a nurse, they really drum that into you because we give blood a lot in the hospital. It's something that even any nurse in the ER, L&D, med surge, OR, every nurse I think at any sort of floor is giving blood, and the checks, I know I'm talking to all my nurses right now, the checks that we have to do to administer blood to a patient is really a ton, but it's so important, and those checks and balances are in place for a reason to make sure that we don't mess something up because it is a critical intervention. It can cause a lot of harm, but it can also be so beneficial for these patients. And so with the whole blood, make sure it's correct. And don't forget that you could combine TXA with whole blood. And I think there's some really good data, especially in the military, talking about this right now. And I can't wait to see some of the studies that come out further and some of the data points at combining both of those with severe hemorrhage and the benefit of it. And so those are three huge things that I think you should really consider when you're talking about postpartum hemorrhage in the field. And it comes down to what can I give, when can I give it, and how much. But also with that, ensuring that you're giving it for the right reason and that everything's properly assessed. Is this rapid amount of hemorrhage? Is this hemorrhage that's just sort of sneaking up on me and maybe I'm in an interfacility transport or a flight scenario where I really should be keeping a track of how much output of blood is occurring and asking the nurses on the floor how much blood already came out? But these are some great tools, and there's really great data that drives why we have these things available to us in EMS, and how to best utilize them and deploy them in the field. And so, with that being said, Dan, I know that you had a pretty significant case of postpartum hemorrhage. Why don't you tell us a little bit more about that? What you did, and maybe if you didn't have some of these agents at your disposal at the time, how could you have utilized them in that case?
Yeah, absolutely. And I do want to circle back real quick because I think every point that you talked about, TXA, Pitocin, whole blood, we continue to say early recognition, early administration. That's where we're seeing the best results in these studies. And we talk about that continuum of care and the escalation of care. We talk, obviously, yes, we do need to start with our basic maneuvers and our basic interventions first. And we do need to employ those and work our way up that escalation of treatment. But we do need to keep in mind that just because we don't see, the stereotypical crashing patient in front of us at this moment doesn't mean that they are not progressing that way and that these early interventions might and will prevent that from their condition from deteriorating further. So I think it is a balance of trying to find these signs and symptoms early and make sure that we are employing these interventions early, again obviously within protocol and within our limits. But I think this early recognition is incredibly important, because it leads to the early intervention. and
Absolutely.
and with that being said, so yes, I had one. Fortunately, like Will, most of my cases have been pretty routine. They've been pretty uncomplicated, and I am very grateful for that. However, I did have one. This was many, many, many years ago. I was still an EMT with a paramedic partner that does listen to this podcast, so shout out to him. But we got dispatched out for a childbirth. When we arrived, like as we were pulling on scene, 911 says, "Hey, baby is now out." We walk in, and both mom and baby are not in a good way. Baby is borderline needing to be resussed. Mom is bleeding out pretty substantially. And we are just two individuals trying to do our best with what resources we have. So I think one of the most important things when we were very fortunate that there was another chase car medic about 5 to 10 minutes away from a different company. So we were able to early activate them, get them up on scene to give us just another hand with these two very high acuity patients. But one of the most important things looking back on this call that I think of is that the service that I worked for, again, this was probably about 10 years ago, we did not have TXA. We did not have Pitocin, and we certainly didn't have whole blood. We didn't have any of those things. We had oxygen and we had fluids, is what we had for treatment purposes as far as this call goes. So while I was trying to work on baby using the BVM, trying to get baby to come around with that, and my partner and ultimately the second medic that came in on this call were trying to recess mom, who was very hypotensive, tachycardic, and trending the wrong way for both. The big key takeaway from this is you don't realize how much resource utilization goes into one patient, let alone two, when you have these two crashing patients. I do truly believe that with TXA, with Pitocin, with whole blood, with these advanced interventions, that this would have ultimately been a lot more manageable in the field. I do still believe that these early recognitions are some of the most important things. Mother was very anxious. And I think that is one of these signs that we overlook because we talked in the last episode, we fall into these traps of, oh, anxiety. Well, yeah, of course you're a little anxious. You just had a baby and you're not entirely sure what's going on. You know, your body's hurting, your body's not doing great. So, of course, you're a little anxious. Anxiety is routinely the first sign and symptom of shock. That is one of these things that gets overlooked in trauma, in childbirth, where we just kind of say, oh, yeah, we chalk that up to, of course, whatever it is that's going on is what's causing this anxiety. You'll be fine. We'll get you fixed up and everything will be good. But I think with seeing that, with trying to better appropriate the amount of blood loss, with a quicker notification to the hospital, especially in this time where, you know, the hospital has these resources that we didn't have at the time. You know, an earlier notification to them could have had these resources literally at the bedside and ready to go when we got there versus, you know, waiting an extra 5 or 10 minutes. You know, when we talk about this blood loss, especially when we talked earlier about the slower versus the rapid onset, you know, in these rapid blood loss situations, these minutes do count. And, you know, I know that's a very overutilized statement in EMS where seconds and minutes count, but it is very true that these seconds and minutes do count. And by early notification, even just that simple act of calling the hospital 5 minutes sooner could be the difference of that patient getting medications or blood 5, 10, 15 plus minutes sooner than what they otherwise would have. So I think all of these things, even if we don't have, even if we're with a service that doesn't have whole blood or even PIT or TXA currently, these little things that we can do, these basic maneuvers with whether it be an appropriate fundal massage, whether it be early notification to the hospital, these decisions that we make early into an event like this can genuinely change the trajectory of this call. I think we need to make sure that we are taking the time to fully appropriate this. Now, in this scenario, mother and baby did have a good outcome, fortunately, but it is one of those scenarios that still to this day, 10 years or so later, still routinely is in the back of my mind, especially anytime that we're going to an OB call, because you don't forget something like that because it helps you build and helps you make those decisions moving forward.
Yeah, and Dan, one of the most important things that I think you just mentioned was the early utilization of resources. And something that I want to emphasize that you talked about, but I think it went a little bit underscored, was not just calling the notification, not just deploying the medications early if you have access to them, but something that you said that I really want to emphasize is you were fortunate enough to have a advanced life support squad that was 5 minutes away. And the best thing that you can do in these critical calls is just to start that second unit. Just get someone else coming to your location. Start them early because the last thing that you want to do is either have some sort of naive outlook that I think this is going to be a routine delivery. Maybe if your service allows mom and baby to be transported together with the skin to skin, if there's an appropriate way to restrain them in the back of the truck. Obviously, not always the case. And many times, best practices is to transport them separately. As sad as that can be, we want to make sure it is a moving vehicle and this is not a hospital and these patients need to be restrained appropriately, that if in case something bad were to happen, they are safe. But making sure that those resources are en route to you. And so, even if you think it's just going to be isolated to yourself and a BLS unit, since you're on a squad or the MICU or two MICUs, maybe it's a good idea just to get another paramedic en route to the scene. Maybe we just call and see if there's an ALS intercept somewhere that can come meet us on scene. That way, we don't need to have four full staff transporting units outside of someone's residence at 3 in the morning. But making sure that you have those resources coming is something that you mentioned, and I think gets missed all the time. And we're starting to call for backup when it's too late. Because something that I even said earlier is going from one patient to two patients is very uncomfortable and not something that we're used to in EMS. And one of the hardest things to do, and Dan, you talked about it with this call, and I think I don't want to speak for you, but I know for me, if I was in those shoes, I would remember it for a long time because you're then managing two very critical, very high acuity patients with just yourself and your partner until help arrives. And that is really difficult.
Well, and that's exactly right. I mean, the feeling of, I don't want to say helplessness, but the feeling of helplessness essentially when I'm the only one at this point taking care of baby, my partner's the only one taking care of mom. They are both doing unwell at the time, and you feel kind of on the island out there by yourself. And just to echo what you said, working on a squad on the flip side of this, maybe 6 months or so ago, I had a request for an intercept with a MICU on a childbirth. And unfortunately, they called when at the point that I went en route, I was already chasing them. And we were 10 minutes or less from the hospital from where I was. And I'm chasing them, and I just physically couldn't get caught up to where they were because they were running hot to the hospital. And they were coming from and this is not in a blaming sense, but to highlight the need of early recognition. I would much rather be the provider that calls for somebody and not end up needing them versus the other way around, because I know that feeling of being on the island when things are going very south, and I can only imagine what the crew on that MICU was dealing with.
Yeah.
And you almost feel guilty because it's like, hey, if you would have called me 10 minutes sooner, I could have been there and I could have helped. And again, not in a blaming way, but just to highlight the importance of early activation. It's so much easier to get somebody turned around and not need them than the other way around.
You couldn't have hit that anymore. It's just really vitally important, and especially as we talk about deploying and getting these resources early. As we close this episode out, I just want to remind everybody that look into the data. And so again, I want to say that that early use of TXA really looks like it's making a difference. There's a lot of promising data out there. Pitocin, if you have it available to you and it meets the criteria to be administered, can be administered first line. It's one of the first things that you could do following that fundal massage, just to try and get that uterine to contract a little bit more. And as we progress in EMS and talk more about whole blood and blood products, I would urge you to get those on board sooner than later. Like Dan said, these patients are going to be anxious and we shouldn't write that out. And then also monitoring those patients' vitals. That tachycardia that's still persistent 30 minutes after birth might not be because they just gave birth and are really excited. It might be a more grave and sinister finding that we really need to address in the field and make sure that we're managing these patients so that before they become hypotensive and before they begin to crash, we're already on top of things. Because as much as you hear it, it is so true in postpartum hemorrhage that every single minute counts. And yes, you hear it in EMS all the time, the seconds and the minutes count, but these patients are really critical and really require that early intervention. And with that being said, I want to really pose a question to a lot of the L&D nurses that are out there. Would love to hear you guys comment on our TikTok, on YouTube, on Instagram. Shoot us an email or a DM. Let us know some of the most severe cases that you've seen, because this is something that you are witnessing every single day with your work. You are on an L&D floor, and so the experience that you have, we really want to tap into. Can you give us some advice, some tips? Let us know some of your best practices for managing postpartum hemorrhage patients and also just managing mothers that have just delivered a baby. You have the most exposure and some of the best advice. So I really want to ask you about that. But that's all that I have for this episode. Dan, do you have anything else you want to say?
I love what you just said there. I think we, as we talked about at the beginning of the episode, getting whatever information we can from the L&D nurses is massive. And I think if you're out there and listening, please, like Will said, we all, as an entire audience, want to know. We're all here because we want to learn. We want to know what more we can do to improve these outcomes for our patients. So, absolutely, let us know what we can be doing, anything that we might have missed, or any additions that you have for what we talked about here. And I would throw another note on that as well, is that some places have the ability to, when we're making these notifications, rather than just simply calling the emergency department, nurse or tech or whoever answers the radio or phone, or even calling the emergency department doctor, if you have the ability, talk to the OB team. If you have that chance to talk to the on-call doc, that is the OB doc, that is going to be taking care of this patient when you arrive with them, and being able to establish that early rapport with the OB, excuse me, as well as them having the early information and being able to work with you directly in their care, only further improves that continuity of care. So if that is something, even if it's maybe not necessarily something in place, maybe the next time you're up on L&D on a routine, ask them like, hey, if I have an OB call where I need some guidance, then again, obviously make sure you're following your protocols. No, they might not have the command or control feature that our emergency department docs do, but still, they're a doctor that's going to be taking care of this patient. Operate within your scope, but if you can have that conversation with that OB doc, that alone could be a massive resource in managing these patients pre-hospitally.
Absolutely. Well, Dan, with that being said, until next time, trust what you know, treat what you see, and always remember to stay curious and stay humble. And we'll see you on the next episode.
See you guys next time.